Hello, my name is Tony Finch, and I'm the Executive Director of the Oregon Oral Health Coalition, or OROC. I'd like to welcome you to the First Teeth First Committee's Lunch and Learn series of 2014. OROC's First Teeth First Committee, previously known as our Early Childhood Caries and Prevention Committee, is dedicated to developing programs and resources for the prevention of early childhood caries. The First Teeth First Committee works in collaboration with many stakeholders and communities to address oral health issues and prevention from as early as pregnancy through the preschool years. You can learn more about the committee and how you can become engaged by visiting www.oroch.org. At this time, I'd like to turn the webinar over to Philip Giles, OROC's Operation and Communications Manager.
Hello and welcome. Please note that registration for this webinar is over capacity, and we encourage participants from the same office to share a computer if possible. The webinar presentation will focus on the basics of motivational interviewing techniques and how motivational interviewing was successful in the Baby Smiles project. The Baby Smiles project aims to provide better utilization of preventive dental care and improve the oral health of rural, low-income, pregnant, and postpartum women and their children to increase the number of oral health practices taken by these women to prevent caries in their young children. Our speakers today are Ariel Singer, MPH of OHSU. Ariel is the Program and Training Director for the Northwest Addiction Technology Transfer Center, and Dr. Peter Milgram, Professor of Oral Health Sciences at University of Washington's Baby Smile Project. Each presenter will present for 20 minutes, followed by a brief Q&A session after the webinar. Please use the question box to submit your questions or comments. At this time, I will turn the webinar over to Ariel Singer.
Hello, everyone. Thank you for having me. I'm just going to take a moment to pull my slides up. Just give me a second here. So I have about 20 minutes to share some information about motivational interviewing with you. So what I'm going to do is just give you a quick overview of what motivational interviewing is all about, just its basic premises and how it works. And that's essentially all we'll have time for today. And if you're interested in additional training, please feel free to contact me at any time. I have my email address listed here, and Philip will be distributing the slides. And I'd certainly be happy to talk with you about additional training options, if that is something that you're interested in. So motivational interviewing is a really excellent framework for promoting patient-centered communication, but it's really a lot more than that as well. So not only is it really good healthcare communication principles and practices, but the thing that really makes motivational interviewing distinct and powerful is the ways in which it can help people change their behavior in order to improve their health and well-being over the long term. So that's really what motivational interviewing is very good at doing. So let's think a little bit about where we're coming from in terms of healthcare communication. So this is a comic strip that we can probably all relate to, potentially on both sides of this equation, because just as much as we are healthcare professionals, we're also patients. So you may be able to relate both to the doctor here who is giving Hagar all these instructions about what he should be doing to improve his health, and you may also be able to relate to Hagar himself and his reaction to this doctor's lecture, which is to stop listening. And that's a pretty typical or common normal human reaction that we have when we are being lectured, is that we just kind of tune it out. And so thankfully, we're all in the healthcare system undergoing all these different transformation efforts and working to come out of the dark ages. And this concept of patient-centered care is really becoming very popular, and now it's our task to try to figure out how can we actualize this concept? How can we change our culture, our habits, and our approach so that we are truly engaging in a patient-centered healthcare system and promoting the likelihood that our patients will listen as we speak to them. So I'll ask you to think for just a moment about your current approach to talking with patients about health behavior change. So when you think about discussing oral health habits with patients like flossing or regular toothbrushing or coming in for cleanings or the various oral health habits that you talk to patients about, maybe eating less sugar or quitting smoking, there's really a range, of course, of behaviors that you might discuss with patients relating to oral health. What's your current approach like? What kind of reaction do you see from people when you are discussing these kinds of habits with them? When you follow up with your patients after you've had these conversations, have they changed their behavior? And how do you feel during and after one of these conversations? So I'll invite you to reflect on that for just a moment, and then to also think about what is your hope for how these conversations would go and what their impact will be. What is it that you hope to accomplish in these conversations, and what outcome do you hope to see as a result? So we don't have time to actually have a discussion about this, but something to mull over and to consider for yourself, what your experience has been and what you'd like it to be. So let's go on to talk about more about behavior change. So why do people change? We know from research into health behavior change that people change for a variety of reasons. They change because they think it's important and that the change is worth it to them, that it's aligned with their values. They have confidence that they can do it, and they have a sense of empowerment, activation, this belief that they are in charge of their own health. They have a good plan. The pros outweighs the cons, and they have adequate social support. They have the resources available to them that are necessary to engage in a behavior change process. So on the flip side, we can also ask the question, why do people not change, and then what is our role as healthcare professionals? So I think one of the ways we could think about why people don't change is just as the converse of all of the reasons we just listed for why people do change. And so then when we think about what our task is or what our role is as healthcare professionals, I think that it's a better way to approach people to think about not our role as being having the goal of persuasion, of trying to get people to change. Instead, to ask ourselves the question, how can we facilitate a process of people connecting with all of those internal factors that support change? How can we help people connect to their sense that change is important to them, that the pros of changing outweigh the cons of changing, because change can be very difficult. They feel that it's important, that they are capable, they have a plan, they have adequate social support, so all those things that support behavior change. How can we help people connect to those factors within themselves? So let's continue thinking about health behavior change. And I want you to think about a health habit that you've been wanting to change. Maybe someone else has told you that you ought to change. Maybe it's just your typical health habit that many of us consider changing. Maybe we think we should get more exercise. Maybe we should be getting more sleep, eating more vegetables, eating fewer French fries, drinking more water. So we all have this variety of health habits that we kind of have carrying around with us at all times of I should be doing this, I should be doing this, and maybe we're doing it a little bit but not as much as we want to be. So we have these thoughts of change. And think for a moment about why you haven't changed those things if you want to. You probably have a variety of reasons why you haven't been able to make those changes that some part of you wants to make. So a much more respectful way And the basis of motivational interviewing is to think about this not as noncompliance, which is our typical label for patients who are not complying with medical advice, but instead to think about them as ambivalent, of having the experience of feeling two ways about something. The feeling of, on the one hand, I really would like to get more sleep, and on the other hand, it's just really hard for me to get everything done in the evening that I want to do and get to bed early enough. On the one hand, I really would benefit from getting more exercise, and on the other hand, it's really hard to fit it into my schedule. So we all have these opposing views. And when we think about noncompliance, really that just means that people aren't doing what we tell them to do. And so rather than thinking about us as the authority on someone else's life and calling them noncompliant when they don't do what we say they should do, instead, motivational interviewing recognizes that change is a more complex process than that and acknowledges that people have these messier experiences of the prospect of change and often, usually, feel ambivalent about changing a habit. So what can happen when we encounter ambivalence? Well, there we go. Sorry, I skipped ahead 2 slides. So let's say a person feels two ways about something, as we've just been describing. And we, as helping professionals, really, with all the best intentions, want to help them make the change. So we start pushing for change. We give them all these good reasons why they should change. We tell them what horrible things might happen to them if they don't change. We use all our best tactics of persuasion to try to promote change. Now, when someone's ambivalent, what does this evoke in response? So this is something that you're probably all familiar with. This is the yes, but. That's what is evoked in response to persuasion for someone who's ambivalent. This is very typical, and we've probably all been in conversations where we were trying to convince someone of something and what we were getting in response was yeah, but. And we've probably also been that person on the other end of the conversation when someone else was trying to persuade us, and our natural reaction was to not totally disagree with them because we're ambivalent about it, and at the same time to go ahead and take up the other side of the argument because we see it both ways. And so what we can end up doing is actually getting people kind of digging in their heels and just talking more and more about all the reasons why they don't want to change or can't change or shouldn't change or whatever. So what we want to do is acknowledge that ambivalence is really a normal part of a change process. It actually shows that change is possible, because if someone's not even ambivalent, if they've just had their mind made up that they're not going to change, then there's much less hope than if they're ambivalent and they see some benefit to change. So we want to focus on that. So basically in MI, we're recognizing, again, that human change is messy, and that while we might really wish that it looked a lot like the dreamland version of change over here on the left, with this just straight trajectory from point A to point B, everything full steam ahead, what it really looks like is much more like the real world over there on the right side of the slide. And sometimes we take 2 steps forward and several steps back, and we have the opportunity to ask ourselves how we want to accompany someone on their journey. And maybe we only get to be with them on one small segment of their journey through life and their journey through their health. And what part do we want to play as we accompany someone through the much messier experience of life than what we learn about in a textbook of what healthcare delivery should look like? So what we've been talking about over these past several minutes is the spirit of motivational interviewing, the attitude that we take in MI. So what you can see over here on the left, we have a compare and contrast here between this more traditional approach to not just healthcare, but also education, criminal justice, a lot of the different settings in which motivational interviewing is being used, where there's a pretty authoritarian approach. It's much more confrontational and persuasion-based, educational, this belief that if we just give people all the information, then they'll make the decision we want them to make. And instead, in motivational interviewing, we recognize that what's more effective in helping people change is creating partnership, approaching people with acceptance for where they're at and what they want for their lives, always having a basis of compassion from which we're operating, keeping in mind that we are working on behalf of our patients and we're not using any tactics of manipulation here. And then finally, evocation, this idea that change has to come from inside. Motivation is not something that we can install in anyone. It has to come from inside a person's own experience and value system. And so how can we go about drawing that out? So what we can think about, again, another way to look at this is this continuum of communication styles that you see across the bottom of this screen. This idea of, on the far left, a very directing style where the authority figures tell the individuals what to do. And then all the way over on the right, a very following style where there's not really any direction coming from the professional. It's just a very kind of patient following way of interacting. And then what we do with MI is come down in the middle between these two styles in what we call guiding, where our job as a guide is just as you think of a mountaineering guide or a guide you might hire in a foreign city. Their job is to help your trip go easier and to help you navigate unfamiliar terrain, to help you think about what it is that you want to experience while you're on that journey, to facilitate those processes. At the same time, they're not going to pick you up and carry you across the mountain or around the foreign country. You have to go on your own journey. And in the same way, we take that approach with motivational interviewing, knowing that we really cannot take anyone else's journey for them. So one really, really essential aspect of the motivational interviewing approach is this idea of autonomy support, that it's really not our decision to make about other people's lives and their life habits. And this is one of the ways in which I think motivational interviewing contributes a great deal to prevention of clinician burnout, because this very proactive effort is underway at all times in a motivational interviewing interaction to remind everyone, both the clinician and the patient, who's in charge, and it's the patient. And so you can do all of your best change partnership work, and at the end of the day, you are not responsible for someone else's change. That is their journey to take, and you are there as a partner and as a guide. And this very proactive effort to remind everyone of that makes motivational interviewing a very good approach for preventing burnout. So let's answer a few technical questions about motivational interviewing. So what is it for? Well, it's a collaborative conversation to strengthen a person's own motivation for and commitment to change. So this is a summary of the things we've talked about so far. Why would I use it? Well, it's an evidence-based, patient-centered counseling method for addressing this very common problem of ambivalence. And it does that by paying particular attention to the language of change. So it's really about dialogue and inquiry-based conversation. And it's effective both in reducing harmful behavior and also promoting healthy behaviors. So in a nutshell, if we want to ask the question of how it works, we can really think about this quotation on the top half of this slide here, that when a person feels accepted for who they are and what they do, it gives them the freedom to consider change instead of needing to defend against it. So rather than evoking defensiveness, evoking the yeah but, invoking the feeling of I gotta dig in my heels and protect myself and my territory, we invite people to consider what it is that they want in their lives. And through that process of partnership and inquiry, we can accompany someone along the way as they identify what their internal motivation for change is and what their intentions for their health look like. So this is the basic toolkit of motivational interviewing. So we have, as we've described, the spirit on one side, and then we have the actual communication skills that we use to conduct these motivational interviewing conversations. And the core toolkit of the communication skill set includes open-ended questions, affirmations, reflections, and summaries. And in the lengthier training, you would learn and practice all of those communication skills in context of MI. How do we put these things together to strategically promote motivation for change? So the idea behind all of this, if you were to ask, well, really, how does it work, is based on this quote from Pascal that we can see is from a very long time ago, and which still holds water. People are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the mind of others. So essentially, in motivational interviewing, what we're trying to do is to create a conversation in which our patients are talking themselves into changing, into moving towards our shared goals of better health, and beginning to undertake the daily habits that will contribute to better health in the long run. And this is really effective across a variety of different healthcare domains because it really just taps into this feature of human nature that we can observe and have been able to observe for hundreds of years. So what we're after then in MI is trying to evoke change talk. So change talk is statements that reflect motivation for and commitment to change. These are things that naturally occur in conversations about change with someone who has any motivation at all to change. And our task is to strategically go about mining for and then reinforcing change talk. So I'll give you just a quick example of what change talk sounds like. So we often refer to change talk with this acronym of DARN. So this is the type of thing that we might hear: desire, ability, reasons, and needs to change behaviors in order to improve oral health. And I've given you examples here that reflect behaviors that relate to oral health care. So just quickly, in my last slide, what I'm going to share with you is a little bit of evidence on MI and oral health. So this is a new area of research. Motivational interviewing originated about 30 years ago in the field of addictions, and it has since been used in a lot of different settings and investigated in a lot of different settings, although the research on MI and oral health is fairly new. And so what I found in looking through the literature is that there is a summary of 4 empirical studies that concludes that MI is effective in both cavity prevention and also supporting patients' efforts to attend their dental appointments regularly. And then there's also a greater amount of evidence that MI is effective for intervening with other behaviors that affect oral health, such as smoking, substance use, diabetes management, healthy eating, a lot of the related behaviors, since of course our mouths are not disconnected from the rest of our bodies. And so MI is effective in helping people overall lead healthier lifestyles, which contribute, of course, to better oral health. So that brings me to the end of my slides and my time, and I'll look forward to your questions after we hear from Dr. Milgram.
Thank you so much, Ariel. At this time, I'm going to turn control over to Dr. Peter Milgram.
Okay, so I need to bring these slides up here, I guess. We'll do that. Philip, can you see the slides now?
I can. It looks good.
Okay, very good. Well, good afternoon, everybody. I'm pleased to have a chance to talk to you about the work that we've been doing. Let me first say that we couldn't have done it without the really active cooperation of folks in the health departments in Wick, in Douglas, Jefferson, Josephine, and Lincoln counties. They certainly deserve kudos for their efforts. The other group that was absolutely essential to this work was the managed care programs in Oregon, particularly Advantage Dental Plans, Capital Dental, and Willamette Dental Group. And of course, they did headstands to try to make the work that we're doing effective. And we'll talk a little bit more about that as as we go along. So Baby Smiles is the short name for a very long title for a research project that really deals with the concept that oral health is an intergenerational problem. That is that the focus can't be simply on children's health. It has to be on mothers and children, because mothers, of course, are the source of much of the dental disease in terms of infections, and they're also the source of all good things in terms of child nurturing and taking their children to the dentist and brushing children's teeth and so on. So to think of this as just a child problem is unlikely to be very successful. So that's the basis of this. I'm going to now show you the basic design of this study. So this is a large clinical trial that was sponsored by the National Institutes of Health. Because it's a study, it has strengths, and that is it's very rigorously done. It has some weaknesses in that it has to be very rigorously done and can't completely adapt to local conditions. It has to be uniform. So in those 4 counties that I talked about, Douglas, Jefferson, Josephine, and Lincoln, what we attempted to do was to, first of all, intervene during the perinatal period, during the prenatal period. As most of you know, most women who are served by the Oregon Health Plan, by Medicaid, don't actually get prenatal care until their 2nd trimester. So what was happening previously was that even if the women wanted to go to the dentist and they knew they had coverage, they often didn't really find out about this coverage during pregnancy until partway through their pregnancy, and then when they attempted to make an appointment at a dentist, they often were given an appointment that ended up in the 3rd trimester or later, and the consequence was that it became very difficult to go to the dentist. So our intervention was as early in pregnancy as it could be, and we intervened either using a brief motivational interviewing approach, and I thought Ariel did a good job of explaining the basics of that, versus a more traditional health education approach. So essentially, when these women knew they were on Medicaid, we found them through the WICs and through the health departments and invited them to be part of a randomized study where they either were assigned to a counselor in their county that provided brief motivational interviewing focused around the woman going to the dentist during her pregnancy, or a more traditional health education approach. Both of these approaches were scripted, so they were highly controlled, and the fidelity of the counselors in each of the counties was monitored, so that we knew that they were both following the script and that they were all doing it the same. And they were continually retrained throughout the whole period to make sure that that they were faithful to the approach that we were choosing. And basically, as you can see across the top there, our thinking was that we would, through the motivational interviewing approach or through the education approach, change their readiness status, their readiness to go to the dentist, and that we would then move them to an action stage where they would actually go to the dentist, and that ideally they would follow through. And some of the things that we, of course, were concerned about were being afraid of the dentist, or depression, stresses and strains of being pregnant and being poor, and so on. Then what happened in the design was that there were occasional callbacks, and after the baby was born, for the moms whose baby was healthy, the women got additional calls, and they got congratulations on their pregnancy. And then when the child was between 12 and 18 months, the mothers were contacted again. And they were randomized again, so the second time they could get motivational interviewing, or they could get a traditional health education approach, with the outcome, the desired outcome being taking their child to the dentist, as well as to is engaging in some preventive behaviors. I'm going to talk primarily about the utilization data today. So they could be in one of four conditions. They could either have gotten motivational interviewing twice, or they could have gotten motivational interviewing followed by health education, or the other two conditions. So let's go on now and look at the next slide. This just is who the women are. You can see that they were about 24 years old. About 79% of them describe themselves as being Caucasian. That's pretty much typical of Oregon. About 8–9% of them describe themselves as being Hispanic. And you can see that for about half of them, this was their first child, and for the others, they either had one or two or more children. Again, this is pretty much typical of the pattern that we see in Oregon. So this very complicated slide now shows you the disposition of all these folks. And you can see across the top the numbers of women who were randomized into each of the conditions. And you can see how many of them ended up in each condition. And of course, you see that we did lose some women who either we couldn't find because they moved, or we had some miscarriages and some child deaths and some custody battles and all the standard things one would expect to see. So the data that I'm going to show you is based on the numbers that are in the boxes down there at the bottom. So let me tell you, first of all, we measured readiness to see the dentist on a ruler, and the ruler goes essentially from 0 to 10, where 0 is not ready at all to see the dentist, and 10 is very ready. And so you can see that, and you certainly can see below that on average they were pretty ready. Now, when you look at the stages that they were at, again, I mean, you can see that more than 90% of these women were either in the preparation or action stage. So essentially, the group that we got was interested in going to the dentist, and we're going to come back to that because it definitely affects the results of the study. So this slide basically shows you the proportion of women and then children who went to the dentist in each of the individual conditions, and I'll show you the combined conditions in a second. But basically, if you look at maternal attendance, you can see that where it says DMAP, this is the data that the Oregon Health Authority collects. So what they showed, these data showed, was that 85% of the women in the MI group went to the dentist, and 94% of the women in the health education group went to the dentist. And there's no difference. Then if you go across and you look at child attendance, and you look at the MI group, it shows that 46.7% of the women took their children to the dentist, and in the health education group, it was 39.4%. Again, although the numbers are different, they're not significantly different, but certainly encouraging in the sense that at least in the child case, the MI group seemed to have a greater proportion of women taking their child to the dentist. If you go now to the rows at the bottom where it says DMAP plus self-report, a number of the families have some insurance that beyond Medicaid. So the way we captured that information was to ask if either they had been to the dentist or if they had taken their child dentist. The other thing, in addition to their other coverage, is that some of the dentists do not record or not bill for what they call look-see appointments or early, a quick exam on a baby. So the insurance data that's collected by the health authority understates the actual number of children who go to the dentist. So again, as you can see, if you look at the maternal attendance, that's the columns on the left, you can see that when we added in self-report, about 92% of the MI group and 94% of the health education group took themselves to the dentist either during their pregnancy or in the 2 months after their baby was born when they had coverage. On the child attendance side, you can see that the MI group had about almost 54% of the women taking their child to the dentist, and the health education group had about 52%. Again, there are no differences between these conditions. So let me just show you one other thing here. So if you combine the groups together, and you look at the group that just got MI versus, say, the group that just got health education, that's the first column and the fourth column, you can see, and the rows, again, are DMAP data only at the top, and then the combined DMAP plus self-report. If you just look at that for a second, you can see that in the MI group, about 52% took their child to the dentist. In the health education group alone, about 47%, almost 48% took their child to the dentist. Again, there are no differences between these conditions. So you might ask, well, okay, doesn't seem to be any difference between these conditions. How does that relate to the state as a whole? So if you look at the PRAMS data, and PRAMS data is the data that the state collects that's self-report. If you look at mom attendance during pregnancy of going to the dentist, statewide it's about 45% during the same period that that we're talking about here. So we go back for a second here to the slide with mom on it. Again, the columns on the left, you can see that we had, with the insurance plus self-report, we had between 92 and 94% of the mothers going to the dentist. So 45% statewide. In the counties that we studied, the rate is higher. It's about 60%. But again, we still have the difference between 92 to 94% versus 60%. I think most of us, statistics aside, would consider that a rather big success. If we look at the child attendance, again, if we go back here to the less complicated slide. So if you look at the child attendance, the statewide rate for children going to the dentist during essentially their first year of life, this was again around 18 months when we were looking at this, the statewide rate is 35.6%. So if you look at the combined rate across our conditions, the lowest condition, the health education condition, is almost 48%, and the highest response, that MIHE column, is 56%, compared to 35.6% statewide. So again, I mean, this is a roaring success in terms of what we would have expected statewide. But what is more striking is that the rate of attendance for children at 18 months at the dentist in Douglas, Jefferson, Josephine, and Lincoln counties is 8%. So we pushed the rate up by 400-fold. A huge, huge increase in the rate of going to the dentist as a consequence of this, in spite of the fact that there were not these differences between the two groups. Whoops, sorry. Let me just, didn't mean to do that to you. There we go again. Let me, Sorry. Go back again. Let me just finish by giving you a little bit of an explanation of what we think is going on here. When we studied our first attempt at a kind of unstructured motivational approach to getting moms to go to the dentist in Klamath County, working with WIC and the Klamath County Health Department, we found of moms going to the dentist was extremely high, like you're seeing here. And so we interviewed a group of those moms to try to find out what actually happened. And we found out two things that were really important. The first was that many of the mothers did not know that they had coverage. They did not know they had insurance coverage. The second thing we found out was that they didn't think they were welcome at the dentist. And that probably will resonate with many of you. And what they told us was that when somebody helped them navigate the system, that is, when somebody told them that they had coverage, they went to the dentist in droves. And part of the design of this study, the Baby Smile study, included the patient navigation function in all the conditions. That is that the community advisory committees decided that it would be unethical not to provide this patient navigation function in all the conditions. So, and the managed care plans agreed to have centralized phone numbers for appointment making and to give every pregnant woman who called who was on Medicaid an appointment within 10 working days. And so, our conclusion is that we had a group of women who were ready to go to the dentist, were contemplating it, and were at the stages of change, that goes with the motivational interviewing model that would likely mean that if the barriers were dropped, they would likely go to the dentist. And indeed, with a little bit of help, in making appointments and following through, the women went in very large numbers. Now, for sure, any kind of study like this suffers from what we in the trade call selection bias. And that is, the people who sign up for these things tend to be the people who are more ready. And so that's not saying that if you had the opportunity to use these kind of brief motivational approaches with women who might not be quite so ready, that you might not, in fact, find that the motivational interviewing would be more successful than the health education. But under the conditions that we were able to study, there was no difference. Now let me just finish by just telling you something about the cost of all of this. To do the straight health education approach, where the women had appointments and where there was this highly scripted health education approach, it cost about $190, $191 to do that. That includes multiple visits for health education and some follow-up telephone calls. In the motivational interviewing conditions, where in both cases they had motivational interviewing, the cost was about $361. So you have a pretty substantial, more than $150 difference in the cost of delivering the motivational interviewing versus the health education process. So I now would be glad to respond to questions or to let you ask Ariel some questions.
Okay, thank you all. Great presentations from Ariel and Peter today, and you can now use the question box to submit your questions. And that question box is located in your GoToWebinar tab. And we're just waiting for questions to come in at the moment. Okay, here we have a question from Kelly Barnes, and the question is, what specifically increases the cost of the MI group compared to traditional education?
Is this mic live? Yes.
Yes.
Kelly, thank you for your question. Yeah, what specifically increases it is the amount of contact and follow-up time. Lots more contact time and lots more telephone time. The other thing that increases the cost is that there are some training costs embedded into this, and of course the counselors that were doing motivational interviewing had to be very highly trained and scripted.
We have another question from Michelle. Will this presentation be archived and available on the OROC website? Yes, both presenters' materials as well as the recording of the webinar presentation will be housed on our website hopefully by the end of this week. We have another question. Dr. Milgram, what are the care included with the $191?
The $191 is not care. The $199 is the cost of the counseling, and that is the value of the counselor's time in walking the women twice through a health education program. These things were in notebooks and on computers. So they watched health education movies, standard kinds of. They were given brochures and so on. So it's the value of the time. You might be actually interested. One of the things that you might be concerned about is that the women would go to the dentist and they would get a screening or an exam and not get any care. This, often happens in Medicaid populations. The dentists take them initially, but then they kick them out. These women, half of them got restorative care, for example. So they actually, the level of care that they received actually was quite high.
Thank you, Peter. We have several more questions just popped in. Do you have a specific MI training model that you could recommend?
Yes, actually, Dr. Philip Weinstein, who is a colleague of mine, actually has a loose leaf textbook which is available fairly inexpensively that is MI specifically for folks working in dentistry.
Great.
In fact, when Ariel was talking about the studies of MI previously, he's the author of several of those.
Oh, great. Okay.
Can I add something to that?
Absolutely.
So I would also want to put in a plug for having, if possible, live training with someone who can facilitate skill building practice and give feedback. Really what's considered the gold standard in learning motivational interviewing is to get initial training and then have some kind of process of observation and feedback so that an expert can let you know how you're doing and help you improve your skills. So I think textbooks are a great way to learn about MI, and getting training and the opportunity to practice in real time is also extremely valuable.
Great. Thank you, Ariel. I have a two-part question for Peter. What happened to the utilization after the study finished?
That's a great question. We've actually proposed to study that, and we're waiting to see if we can actually get the money to be able to follow up and do that. I would say that at least with the Advantage dental programs, Advantage is the largest managed dental care company in Oregon now and has the largest book of business across the state. And they actually are training their own people to use motivational interviewing techniques. They do a lot of telephone work. They actually have a care management staff that interacts with clients in addition to much of their field staff. And Charity Ludwig, who is a dental hygienist, is the quality assurance manager for Advantage. And she was the original counselor that we used down in Klamath County. So there's been, at least on the Advantage, which covers a lot of your rural counties, there's been some real adoption of some of these techniques.
Great. And then part two of that question is, was there any attempt to see whether the longer-term effects differed, either in terms of the oral health of the children or utilization in general?
That's also a great question. In the work we did in Klamath County, we did actually follow up the children, and we've actually published a paper, which I certainly could make available, or reference could make available, which showed that when we followed up children at 2 years old of the mothers who had been part of the Klamath County experiment, that the mothers who got the counseling had children who were much more likely to be caries-free than the children whose mothers didn't get that counseling, even adjusting for differences in race, for example, in that county. We have a proposal in to follow up the Baby Smiles families, and we are simply waiting to see what happens with the funding for that.
Great. So we have a few more questions. This one is, I believe, to Peter as well. How do you address assuring pregnant women understood dental services are covered and are welcome to receive dental services?
Well, again, I think that as I mentioned, the patient navigation function turned out to be a critical function, both in Klamath County and now in these new counties. In that, the women learned as part of their experience with the counselors that they had coverage and how to use it. They were actually helped in making appointments. So we took down most of the barriers, and of course on the managed care side, the providers had already agreed. I did really extensive continuing education both for dentists and for primary medical care practitioners in the counties, and went, for example, to most of the pregnancy care providers in these rural counties and actually talked to them about what we were doing so there wouldn't be any barriers from the physician side. And then most of the dentists who were serving these women in these counties attended at least one continuing education class where they learned about care for pregnant women. They learned some strategies for working with the families, and they also learned what was appropriate for children.
Great. Now we have two more overall questions about motivational interviewing themselves. The first one is, how do you measure return on investment for motivational interviewing?
I'm not sure who that question is.
I don't know if you have it. Yeah, me either, but I will say that I think that there would be a pretty complicated answer to that question. I don't have one offhand.
Okay, thank you. And the other question is motivational interviewing an effective method for communicating with patients of all ages or just with adults?
Well, Dr. Milgram, I don't know if you have anything to add, but there's definitely a body of literature that I'm aware of motivational interviewing with adolescents, and it will probably work with children, although not very young children. There is some reasoning skills that are required to be able to engage in a motivational interviewing conversation, but it certainly has been used with adolescents successfully.
Well, I'd like to take this time to thank you all for coming out. I know you're all very busy, and we hope that you learned a lot about motivational interviewing and the Baby Smiles project and how they can help your organization and community. Again, presenter materials and a recording of the webinar will be housed on the website later this week. Please email myself, Phil, at philip.giles@ocdc.net. That's philip.giles @ocdc.net for any further questions or comments. And again, thank you so much for attending, and enjoy the rest of your summer.
Thank you.